Thank you for getting us all set up. Welcome everyone. I'm Dr Katrina Moss and I'm part of the Australian Women and Girls Health Research Centre under the leadership of Professor Gita Mishra. And I'm really thrilled to introduce Dr Danielle Schoenaker today, who is a Senior Research Fellow with the MRC Lifecourse Epidemiology Centre at the University of Southampton in the UK. And Danielle currently holds an advanced fellowship from the National Institute of Health and Care Research. But before she got fancy, she actually did her PhD here in the School of Public Health and was part of Gita Mishra's team as well. So we're thrilled to have Danielle talking to us about her interesting program of work today. And she's going to be focusing on using epidemiology and community engagement to inform policy and practice change to reduce inequalities in preconception health. Welcome, Danielle.
Thanks very much, Katrina, for the really kind introduction. It's really nice to be back. Lots of familiar faces and also nice to meet new people. I walked around this building for about 6 years between 2011 and 2017. I think when I first came, I did a master's dissertation with Gita and with Annette, and then they convinced me to stay on work as a research assistant for a year. Then I had no idea, but the idea was probably for me to get a PhD scholarship, which then worked out. So then that added another couple of years of PhD time. So I looked at how nutrition before pregnancy influenced risk of developing complications during pregnancy. So looking at preconception nutrition. And as you can see from the title of my talk today, it's my work is still focused on preconception health and care, so no longer necessarily focused on nutrition, but just wider kind of preconception health. I also still work in epidemiology, but also doing qualitative work now and working with the community to inform what we do and how we disseminate it, ultimately to not just publish papers, but to inform policy and practice change. And I think that some of you at least will be able to relate to that. So I'm hoping to kind of have a bit of a discussion afterwards as well. So I'll share what we're doing in the UK, but looking forward to learning from all of you as well. So I'll get the slides moving. I thought I'll go back first a little bit. Some of you might recognize yourself here because this is where it all started. This is actually one I got online, so it's not even because there was one from 2 years earlier that I couldn't find anymore, but this is from one of the annual reports. And so I was, yes, exactly. Hiding there, yes. It was really great to be part of the CLLR, Centre for Longitudinal and Life Course Research. Lots of happy faces. We worked really hard. We were really productive, I think, which really helped me at the start of my career. A few more pictures because there was lots of good memories. Gita and I met again a few weeks ago at a meeting in Italy. And I think we concluded that we hadn't changed. So I thought I'd prove that. You can have your own opinion on whether we changed or not. But that was 2017 when I finished my PhD, and then just a few weeks ago at a winery tour in Italy. Also, I've been away for 8 years, but I've been coming back every now and then. So Evelyn and Louise will recognise, and Hong is there as well, for those of you who know Hong. So kind of kept coming back to Brisbane to catch up with friends. And some of you will remember Caroline Jackson and Case Potatoes as well. They were postdocs when I was doing my PhD here. We're all on the same side of the world again now, so I see them at least once a year in Scotland and in the Netherlands, which is really nice. We're still eating cake as we used to do here, so not much has changed, but we've all moved around a lot, but all still in touch. So not just lots of hard work, but some really good friendships there as well. So for those of you who know me, I thought I'll tell you a little bit about what happened, how did I get to where I am now, where did I go after I left Brisbane in 2017. So I first moved to Melbourne to work at the Cancer Council Victoria. I was part of the behavioural science team there, something completely different, a little step outside of academia to see what that was like. Worked on evaluation of public health mass media campaigns related to tobacco, and alcohol harm reduction, which was a really nice time. And I then had the opportunity to go back into academia, sort of a postdoc at the University of Wollongong, to go back to epidemiology and maternal and child health, which I then took on. So moved about a year and a half after being in Melbourne, moved to Wollongong. That didn't really work out there. It was a really nice place to live, but in terms of the postdoc, that didn't work. And at the time I was exploring collaborations elsewhere across the UK, but across Australia, but also connected with people elsewhere to see how we could work together on preconception health, kind of going back to that topic. And I then visited Southampton for a few days, and somehow around that time they had advertised a job that seemed to be written for me. It was all about big data and preconception health. And so I applied, and then didn't expect to be moving and leaving Australia, but then made the move to the UK in March 2020, which was a very difficult time, not an easy start. But as you can see, I've remained in Southampton. So after, I think, 3 short-term contracts between 2020 and 2022, I've called it postdoc 3 rather than 3, 4, and 5. I know many of you can relate to this. I then started applying for fellowships because I was really keen to stay, really enjoyed working with the team there, felt really supported. So then got an internal faculty of medicine fellowship to give me time to apply for external fellowships, which then worked out quite quickly as well. So now funded through the National Institute for Health and Care Research on a fellowship. And this year we've also been successful with a larger program of research where I'm going to co-lead a preconception health theme within a bigger consortium. So it's all working out, and I'm really having a good time in the UK. I'm planning to talk you through a little bit of the work that I'm doing now. So the move to the UK was really, I think the motivation for that was a few things. The job role really included big data and preconception health, but in the UK we also have a preconception partnership, which brings together researchers, health professionals, policymakers from around the UK who are interested in the topic. And I've always enjoyed collaborating, and this felt like a really collaborative environment where people work together from multiple disciplines. And so I think that really convinced me to make the move to the UK. For those of you, I thought I'll start with a really brief background, because I'm talking about preconception health, but some of you may not be familiar like some of us are, but it really describes the health of women and men during their reproductive years, so during the years when they might have a child. It relates to health behaviours like diet, physical activity, also risk factors like smoking, and also wider determinants of health that influence whether people are able to meet recommendations around health behaviours and risk factors like education, housing, employment, etc. I know in School of Public Health, you're probably all very familiar with this, but this is kind of what we define in terms of preconception health, so leading up to pregnancy, thinking about these risk factors. So it's very much, you can very much see it as a life course approach to health as well. So preconception health can start as early as in early life with school and literacy, health literacy, where you grow up in terms of friends, family, community. During the reproductive years, then there's other things that become important, like sexual health, screening, healthy lifestyle, healthy relationships, and closer to pregnancy, there might be some specific risk factors or healthy behaviours that people can take on who might be planning a pregnancy, such as taking a folic acid supplement. So these are things that are relevant to everyone's health, really, and there's also risk factors that may be relevant for some people, like obesity, smoking, alcohol, and long-term health conditions, which are becoming more and more common. I also wanted to briefly mention that preconception health is not just about people's health leading up to a first pregnancy, but also leading up to a next pregnancy. So you could call it preconception health or interpregnancy health, but it's all about promoting a healthy start to a pregnancy, whether that is a first one or a next one. Why is preconception health important? So why do we care about these, how healthy people are when they enter pregnancy? So many of you will be familiar with the kind of life course approach to health as well, but this is a picture that we often show. So saying that across the life course, people's risk of developing chronic non-communicable diseases increases, and this trajectory can be changed if we intervene, and that is most effective if we intervene as early as possible. That's why this picture starts with preconception health, which influences health of the mother during pregnancy and the baby, and that then goes on to influence people's health throughout their life course. And there's then an intergenerational component going back from adolescence or young adulthood back to them being the parents of the future, really. So it goes back to preconception health as well. So multiple reasons for why starting early and why starting before pregnancy. The case for why health before pregnancy is important was also very much part of the first Lancet series that was published in 2018 that Gita and I were able to contribute to one of the papers, which focused on why preconception health matters. The other two papers were around how it affects future health in terms of mechanisms and what can we do about it. So what types of interventions can promote health before pregnancy. Since publication of this Lancet series, especially in the UK, but I think also in Australia and elsewhere, there's been a lot more strategies, policies, guidelines that have been developed since policymakers and health professionals are more aware that preconception health is important. But these policies and programs are not really evaluated, so we don't really know whether more guidelines, more strategies, more mention of preconception health in various policies, if that actually makes a difference. And to whom does that make a difference, and to whom perhaps not? And how can these policies and interventions be improved? We don't really know that. So after publication of the Lancet series, the UK authors of the series came up with the idea of annual reporting of preconception health indicators or metrics. So this is thinking about what does preconception health in the population look like, how well are people prepared for pregnancy, to identify what they need in terms of programs and services, but also to monitor that over time to see if it changes, if it improves, or if it goes in the wrong direction. So there's a need for more policies and programs. So when I moved to the UK, my postdoc, the task was really to collaborate with people in the UK preconception partnership, so researchers, policymakers, health professionals, together with the Department of Health and Social Care. Within that sits the Office for Health Improvement and Disparities, who do a lot of surveillance work. And so my task was to work with these organisations to develop preconception health indicators and set up a surveillance system, which sounded easier, well, not really, than it might sound. So what we did initially was to think about how can we actually describe the population's preconception health? What are kind of indicators? How do we define them? So I did a review, identified 66 different indicators across these kind of 12 domains. So a lot of the factors that I talked about in some of the earlier slides, like smoking, obesity, various physical and mental health conditions, also previous pregnancy complications. So there were 66 different factors that could describe how well people were prepared for pregnancy. And I then mapped them against sort of existing national data sources in the UK, because we kind of defined the indicators, but where do we get the data from those? We do have a lot of data sets in the UK. There's a lot of cohort studies, there's a lot of kind of national surveys, there's also routine health data. So we identified a lot of those data sets, and most of the 66 indicators that we defined could be found in at least one of these data sources, not necessarily in all, but across these data sources, we could measure and describe preconception health. So to start, we used what we call the National Maternity Services data set, which is a routine health data set that collects information starting from the booking appointment, so the first antenatal appointment when women are pregnant. And in this data set, we found 23 of the kind of 66 indicators, so a good first start, because it takes a lot of time to get access to all of the data sets. So this was one that we could access and get started with the first kind of creating a first picture of what preconception health looks like. And there's 650,000 women who have a live birth in the UK every year. So even for 1 year, we could look at lots of data. And this picture basically summarizes that 9 in 10 women enter pregnancy with at least one risk factor. So basically most women have at least something that they could potentially improve to enter pregnancy as healthy as they possibly could be. A lot of that was related to health behaviors. And the main one was not taking folic acid supplement before pregnancy. Women may not plan their pregnancy, or they may not know that taking a folic acid supplement is something that is important to consider. But also, for example, reproductive health indicators are related to a previous pregnancy and having developed complications was very common for those who had already been pregnant before. And also 1 in 4 had some physical or mental health condition. So that's very common as well. And if that's not well managed, or if I'm taking medications that are not recommended for use in pregnancy, then there's something that they could do before pregnancy as well. So this created like an overall picture of what preconception health looks like. There's lots of inequalities as well, lots of differences, particular when looking at ethnicity. So not taking a folic acid supplement is very common in general, but for example, Black women are more likely not to take a folic acid supplement before pregnancy. They're also more likely to enter pregnancy with obesity. In the UK, there's also a lot of inequalities based on where people live, so based on people's postcodes. So those living in more deprived areas are 3 times more likely to smoke around the time of conception and to enter pregnancy with a mental health condition. I know some of you in the school do lots of work around smoking, so I thought I'll zoom in on smoking a little bit. So on the left, there's some data to show that smoking is still really quite common. I think in Australia, it's the figures would be very different, but 1 year before pregnancy, in the 2018-2019 data, 24% of women smoked about 1 year before pregnancy. And this was 21% around the time of conception. So only a small proportion really quit smoking before pregnancy. But once women then enter antenatal care services and get support, they are able to stop smoking. So then there's 13% still smoking at their first antenatal appointment, which is kind of in early pregnancy. And the graph on the right shows that there's differences before a first pregnancy or before a next pregnancy. So you might think that women get lots of education and support during a first pregnancy, so they may be better prepared for a next pregnancy. But it's actually the other way around, which I think ultra data is also showing. So women are less likely to quit before and in early pregnancy before a next pregnancy. Women will have different priorities, different challenges when they are having a next pregnancy. So that could potentially explain this picture. And one more graph to show that there's really large inequalities based on where people live. So compared with women living in the most deprived areas, those living in the least deprived areas are 2 times more likely to quit in early pregnancy and 3 times more likely to quit before pregnancy. Sorry, the other way around. So it's showing that inequalities in smoking cessation are larger even before pregnancy compared with during early pregnancy. So an opportunity to start addressing these inequalities before pregnancy, because that becomes much more difficult once women are pregnant. So because this was a collaboration with the government, they also published a kind of first what we called report card on women's preconception health in England, which really helped disseminate the topic of preconception health really widely and raise awareness that it is something to consider. Fingertips is our kind of national public health surveillance infrastructure. And so the idea was to continue to work with the government to get these preconception health indicators integrated into our surveillance system, which has been a real challenge because, as many of you know, things in government change really quickly. Priorities are never the same. People move on, and so once you have someone on board a year later, when we're kind of ready to get this onto the platform, things look very different. So it's not been easy. So they are still on board with getting the 23 indicators onto the platform, but at the moment there's only a few. And I've just picked out folic acid supplement use before pregnancy. and which is going down, so less women are taking it compared with, for example, 5 years ago. So I think it does show the value of having these indicators on kind of publicly available surveillance system. And for the government to see this and say, something's going in the wrong direction, this is a really important indicator of pregnancy planning and preparation. So this helps us with advocacy to say something needs to be done. There's also been a lot of interest in this work internationally. So we kind of did this work to prepare a first report card specifically for England, and then presented that at various conferences. And held various workshops to see what was happening in other countries, what indicators did they define, were they doing surveillance. That we knew of a few countries, but a lot of people said, oh, how can we do this in our country? So through various workshops and bringing people together, we decided to set up an alliance, which is called the International Core Indicators for Preconception Health and Equity, or ICIFE Alliance, which now brings together about 80 people from across just over 20 countries that are listed there across all of the different World Health Organization regions. And we've kind of come together, didn't expect this, but initially it was a workshop to explore what else is happening internationally in this space. But we've come up with a study protocol to reach international consensus on core indicators, because there's 66. We can't go to different countries and say there's 66 indicators you have to measure to look at preconception health in your country. So we need to go through some prioritization to define a core set of indicators that ultimately would be measured in multiple countries to support advocacy, to develop surveillance infrastructures, to compare across countries what preconception health looks like, so we can learn from what works in some countries, perhaps not in other countries. It also helps with raising awareness. Health professionals can use it. If we look at it at inequalities as well, then hopefully it can help with equity, and it can help us with accountability of governments and public health organizations. So all of this national work has been used in various strategies and reports. And the international work to develop core indicators has been picked up internationally by UNICEF and World Health Organization. So I've been traveling, and which has been really great, presenting everywhere. And that's kind of ended up with some recommendations in these reports now to say we do need core indicators on preconception health, which has been really fantastic. And just last night, we had the opportunity to present at a monitor meeting. I don't know if some of you are familiar with this, but it's the Mother and Newborn Information for Tracking Outcomes and Results Technical Advisory Group. So they, on the topic of maternal and newborn health, advise WHO on what indicators they should measure and monitor, and that go onto the WHO, I think it's called Global Surveillance Inventory. So they have, similar to what we have in the UK and that you have here as well, they have a surveillance platform as well. So they were really on board with it last night, which was great. Hopefully once we develop our core indicators and have WHO involved throughout the process, some of our core indicators can be part of their, what they call a minimum data set. So let's see. We're just at the start of this. Over the next year and a half, we'll be conducting this consensus study. I'm supposed to be submitting ethics documents this week, I think, so let's see how we go. So these are all kind of high-level policy documents and recommendations, but we've done a lot of work as well, working with the public and with the community, because we can think this is based on guidelines and based on the literature. These are important indicators, for example, to measure, but what actually matters to people before pregnancy? How do they define being well prepared for pregnancy? And if it was up to them, what should we be monitoring? Is that folic acid, or is that something completely different? Also to be able to then support them to improve their preconception health. Where do they want to receive this care and support, and how and from whom, etc. So we've done a lot of work on that. A few years ago, I set up a public involvement group. I think you're calling it a community, how do you call it? Consumers, isn't it? Sorry, in the UK, we're calling it public involvement. I think you're calling it consumer involvement. But set up a group of people sort of aged between 18 and 50 with, of any gender, so a really diverse group, to find out what do the public want and what do they need. And the first thing we found is that they actually have no idea that preconception health is even a thing. So rather than asking them, what do you need to prepare for pregnancy? They're like, preparing for pregnancy, why would you do that? What's that all about? So a first project then became, what does preconception health actually mean to people? And how can we communicate about this so that they actually know what it is and why it's important and what do you do and when? So we developed some language recommendations and public health messages, and then made use of various social media campaigns that were being developed at the time to get some of the messages in there. And national charity Tommy's, they have a web page as well where around planning for pregnancy. And so they used some of the language recommendations that we developed as well, hopefully raising awareness in the community that this is something to consider, it is a thing. And then the next step was to explore, what do people need and where do they want support? So these are kind of priority approaches and settings came up, not necessarily as sort of as a top three, not necessarily in this particular order. But a lot of it was around education and awareness, kind of reflecting that that is a real gap. So school education, and social media campaigns is something that people want, whether we think it's a good idea or not. And also the National Health Service, or the NHS, which is where everyone receives kind of free healthcare in the UK, was an important kind of entry point into starting conversations around pregnancy intentions, and then receiving care and advice based on where people are at in their parenthood journeys. So this kind of informed further discussions. So around this time, I was planning my external fellowship application, and with the NIHR, it's all focused on doing research that directly benefits patients and the health service. So the fact that people said we do want support through the health service as well kind of led me to explore this a little bit further, like who are the health professionals that people want support from, and what kind of part of the care system do people want support? So these are some of the quotes that I used to get the fellowship. So they came directly from the community. So people are really saying they had no idea that there were things that they could do with, to improve the chances of a healthy pregnancy. And while social media, there's a lot of kind of misinformation, but they felt that the NHS was really a trusted source of health information. So the NHS was an important part of receiving support. Then there's also, it kind of kept coming back that people said they did receive a lot of advice during pregnancy, but a lot of the things that they heard, they should have heard much earlier. So before pregnancy, around stopping smoking and updating medications that people are using so that they enter pregnancy as healthy as possible, and that they're healthy during those first critical weeks of pregnancy. Most people also said that they were in contact with a GP or a nurse really quite regularly, or at least once a year. So kind of opportunistically asking about their pregnancy intentions was something that they felt was missing, but something that they would be open to. So primary care was kind of seen as an entry point to preconception care, which also comes from a lot of the literature in Australia. I think it's very consistent. So this then informed my fellowship, which I started 2 years ago now. And I'm lucky to have a 5-year fully funded research fellowship, which aims to generate scientific evidence and also to co-develop practical resources to enable general practice teams to better support people plan and prepare for pregnancy. There's 2 main components to it. So the epidemiology is still something I'm really keen to kind of continue. And so looking to link national data sources to look at the extent to which better pregnancy preparation reduces adverse health outcomes for mother and child, but also health service use, educational outcomes. So eChild is an existing data resource that links data from primary care, from secondary care, maternity services, and also educational data. And they kind of continue to build on that. So millions of pregnancies in there with lots of valuable data. So going through lots of approvals at the moment, but that is one data source to use. And then also looking to use some other data sources through what the kind of NHS England is where most of the routine health data sits and where the linkage happens. And CPRD, you would be familiar with this, but this is kind of primary care data, which is much more difficult to link into other data sources. But because the fellowship is focused on informing preconception care in primary care, is something I'm hoping to achieve throughout the 5-year fellowship. And the other part is really around kind of co-developing, so working with the community to see what care and support they want and what part of that can be provided through primary care. And I'm supervising PhD student Isla Davis since last year, and she's really kind of leading on this part of the fellowship. And I'm hopefully soon recruiting a postdoc to work on the data aspects as well. So I'm excited to be building my own little team. So as part of the intervention co-development, I've started with a first study, which is around kind of identifying what priorities there are. So within a consultation, healthcare professionals can bring up conversations around pregnancy intentions, but they're based on the kind of 66 indicators for surveillance. There's also a lot of risk factors that health professionals can bring up in these types of appointments. And I'm sure it's the same in Australia, but GPs are they have got very short kind of time slots, and so it's impossible to discuss all of that. So the first step here to really develop some guidance for health professionals is to identify what are the main topics that they could bring up if they do find that they're with a patient who may well be thinking about having a baby. So the study is finished, but I haven't looked at all the data in detail yet, but there's 4 kind of priority areas that we identified. They're not really a surprise, but we've kind of gone through this whole process of identifying these. So knowledge of preconception health is not actually part of any clinical guidelines at the moment that kind of say when you're a health professional and you have a patient who might be thinking about having a pregnancy, these are all the risk factors that you go through. Knowledge is not part of that, but based on the process that the consensus process that we've gone through with health professionals and patients, that is kind of the most important thing actually. And then the second one is around ideas, concerns and expectations. So that's mainly related to pregnancy intentions, fertility issues and previous pregnancy complications. And then the 2 that we were expecting, I guess, is related to health conditions and health behaviours. And we can't really pinpoint one over the other because every patient will be very different. But it's just for the health professional to then go through what might be relevant to that particular patient. And so I'm now working with NICE, which is the National Institute for Health and Care Excellence, who do all our kind of primary care clinical guidance, to see how this can be embedded within the guideline that exists at the moment, which includes a long list of risk factors, and a GP would look at it and think, oh, I'm not going to go there. But hopefully if we have something more practical at the top of the guideline, something might happen. And GPs also and nurses kind of work with clinical templates as well. There isn't one for preconception health at the moment, so hopefully this can inform some of that as well, so that it can pull information from their system into a preconception health clinical template that they can then use. So the first kind of initial step, it is then kind of promoting awareness around how to use all of this and how to start those conversations around pregnancy intentions and what advice to give and how to do that, and as part of which types of consultations. So a lot more co-development to do, but we've made a start. And as part of her PhD, Isla is kind of currently working on a systematic review to pull all the literature, really around the kind of implementation type questions around what are the preferences from health professionals and patients around who should deliver it within a general practice team. Is that a GP or is that a nurse, someone else in their team? Who should receive it as well? Is it based on age? What do you do with women and men? Do they both receive preconception care, and how do you start those conversations perhaps differently? When to provide it? Is that bringing up the topic in particular consultations, or can it be anything? There's a lot of differences in the literature around that. So this will give us some ideas on what a potential intervention could look like. And there will then be more qualitative work with patients and health professionals over the next few years to co-develop that intervention and ultimately test it in various general practices. I also continue to use Ulster data every now and then, mainly by including kind of student projects. And I thought I'd pick this one up because it's kind of it was really focused on identifying opportunities for preconception care in primary care. So it's all descriptive, but hopefully I'm hoping to use some of my time in Australia over the next couple of weeks to take this student project forward. But this is data from the 1973 to 78 cohort, looking at how many times have women consulted a family doctor or a GP for their own health in the past 12 months. So a lot of the literature that says, oh, primary care can't really provide preconception care because people don't see their GP. This kind of shows that people do see their GP, and perhaps also quite often. It might change now. I don't know, COVID has changed a lot, so it'll be interesting to, I know there's the new young, are you still calling it the new young cohort? Or, yeah. So the newer young cohort, the picture might look different, but this is kind of initially to look at this. So it shows that more than half of women see their GP three or more times a year. So there's opportunities to build in those conversations around what about a baby? Is that something you're thinking about, to then start those conversations? And these are a few graphs to show, for example, for smoking, that kind of goes down across women's reproductive years. I don't know if this is, I've actually been thinking if this is a time thing, so over time smoking prevalence has decreased, or if it is related to age. But most other risk factors kind of become more prevalent as women get older across their reproductive years. And with women having babies later, this is something that becomes more important. And the data kind of shows in green women who consulted a GP up to 2 times in the past year, and in purple 3 or more times in the past year, where there would be more opportunities to bring up preconception health conversations. And those women who consult a GP more often have a higher proportion of those women have these risk factors. So they see a GP more often, and there's clear opportunities to discuss some of these risk factors in the context of, if you're having a baby, then this is something to find support with. So we're kind of, this isn't published yet. This was a student project, but I'm hoping to turn it into a paper one day. And coming back again to thinking about what the community actually needs. So primary care is one entry point into supporting people to plan and prepare for pregnancy. But there's lots of other settings as well. And when you ask people across, this was not a formal research study, but a kind of community involvement exercise across multiple countries, to ask people what are the most important things to have in place before your pregnancy or before your partner's pregnancy. And these are the words that kind of come up in people's answers. And so health, physical, mental health come up a lot, but also other non-health related things, like a stable relationship, support, financial support, family, security, income, things like that. So it's not just about health. And so we need to think beyond primary and secondary care as well to support people in their pregnancy planning journeys. In the UK, tackling maternity disparities is a really hot topic at the moment. So there's year on year, there's reports to show huge inequalities in the proportion of women who die during or soon after pregnancy. That is much more common, for example, in Black women, those living in deprived areas. This statistics are just shocking. And this image kind of shows that those women who do die during or soon after pregnancy, many of them have physical and mental health problems, but they really have a spider web of problems that are, some are health related, some are behavioral related, but also a lot of it relates to wider determinants of health. And they all occur in isolation. So they don't occur in isolation. Many women have multiple problems, and most of these are present before pregnancy, and they're almost impossible to tackle once a woman becomes pregnant. So this has led to the Department of Health and Social Care in the UK to invest £50 million over the next 5 years to really change these statistics. So the maternal mortality rate goes up and the inequalities are widening. And so last year, we were successful in the application to be part of the Maternity Disparities Consortium. This was taken in Newcastle in north of England in winter in December, as you can see. And so 9 applications were successful. So 9 what they call collaborations are now part of the Maternity Disparities Consortium. And over the past year, we've worked with these other collaborations who we've never worked with before to kind of define themes that the consortium is going to focus on. And with lots of advocacy, preconception into pregnancy health is going to be one of the 5 themes that the consortium is going to focus on, which is really exciting. I think this is kind of going to really take forward not just things like supporting people in primary care, but thinking about a wider public health approach to support people and to raise awareness. So we're kind of at the moment in the middle of developing what we are going to do. So this is my evenings at the moment, UK time mornings. Over the next 2 months or so, we'll have to develop a really detailed work plan, but we hope to create a national blueprint for coordinated preconception and interpregnancy care and support. So initially working in 3 different areas, where there's coastal deprivation or lots of ethnic kind of disparities. So 3 really different areas where we're going to work with the local community, so mainly minoritized communities, and with health professionals, but also with those who work in the community to develop what a support system could look like. And that might be different in the south of England and in the north of England, depending on those communities. And we'll then implement that locally, evaluate it through data and keep updating it over the next couple of years. So really slightly scary piece of work, but I'm really excited about working with people to develop something that will hopefully create meaningful change. But lots of work in this space. And I'm looking forward to hearing what your thoughts are on any of this and how you kind of work with policy or how you do your research to inform practice change. So I'm around today and again all day on Thursday. So looking forward to lots of discussions while I'm here. And big thank you to the groups of people I work with and my 2 main mentors at Southampton and UCL. Thank you. Questions, thoughts, anything? I don't know how I've gone for time. Yeah.
Thanks for a great talk. That's really interesting. I'm Susan Jordan. I'm actually a cancer epidemiologist, but big interest in women's health. I'm really interested about access to general practitioners in the UK. So rumours that you hear based on, I'm not sure what, but is that it's really hard to get into a GP.
Yeah.
And so I was interested to see that the first contact for one of the women was a midwife, and that would be maybe a bit unusual here. Usually the first contact would probably be a GP. So how do things work? What's the kind of system for women who are thinking about pregnancy or who are actually pregnant in the UK?
So when thinking about pregnancy, there isn't really a standard kind of preconception care service where people would go. I think the GP would be the first thing that people think about because they are really difficult to access. Like if you want an appointment, depending on where you live in the UK, you might have to wait 6 weeks. So it's not just rumours, it's not good. Yeah, but I think the GP is kind of the entry point where you can make an appointment rather than going to hospital, for example. So that's I think why it is really important, and GPs understand that preconception care is part of what they should be doing. So the co-development will really think about whether it is through directly, making an appointment and through a consultation, or whether it is what we call an e-consult. So when you want to get an appointment with a GP, you first fill out a long online questionnaire, basically. And so that could identify whether people might be thinking about having a pregnancy, and that could then lead to further signposting, which does not even involve the GP, but it could involve some professional within the general practice kind of setting. So that's kind of what we're thinking about at the moment based on some of the, because we're working really closely with GPs, nurses and patients to kind of see where does this start and where does it go? Does it involve a consultation or not at all? And then I think your question about the midwives, I think there's a difference between the UK and Australia. So midwife in Australia might also provide some care outside of pregnancy, I think, before or between pregnancies. But in the UK, that it doesn't really happen. So it's really from the moment that you find out you're pregnant, you make an appointment and you see a midwife. But I think based on the literature, in some countries, a midwife could have a role, especially in interconception care as well. But I think in the UK, it's a little bit more limited. So it's really, you see a midwife when you're pregnant, but not any other time, really.
Danielle, I have a question, just following on from Susan's question. In Australia, we have the GP Red Book, and there's a list of things that a GP is supposed to ask the women about pregnancy care and it, whether they're advising on folic acid intake, iodine, and so forth.
Yeah.
So there's a whole list that came out in some of your indicators.
Yeah.
So I was just wondering, do they have that in the UK or not?
Yeah, so that's what the midwife kind of does, similar to the Red Book. Yeah. Yeah, so during pregnancy, it's really the midwife, not primary care anymore. So you're saying it's a GP here?
Yeah, it's a GP Red Book.
Yeah.
And some of the work, so we've have a whole bunch of questions. So there's a sub-study called Matches where we're looking at women's preconception, health service use before conception, during and after, and looking at the health of the mother and who actually following, the GP's advice. What we find is basically there's two things, right? Whether they actually keep up with folic acid intake. Actually, in our population, it's only 60% of the women actually comply with the folic acid recommendation.
60% do. That's good though.
60, and then it goes down. It goes down with with the second pregnancy, which is what you're saying. But the main thing that determines, because we're modeling what are the factors, whether the women took folic acid or not. One is pregnancy intention, date important, as you know. And the second one is whether the GPs actually have discussed with them and told them about folic acid. So that is, I think these two seems to be quite an important predictors. But the other thing also that in Australia with the GP guidelines, there's also iodine intake that's been recommended. Now in our cohort, the Matches thing, only 20% actually take iodine intakes, before preparing for pregnancy. I didn't see any things on iodine.
We don't have routine data on that. Yeah, but you might well create a very similar picture where most women have some sort of risk factor before pregnancy.
Yes, what was kind of surprising with some of the work that we're doing is that we thought that maybe women who've had really bad pregnancy, with pregnancy complications the first time, that the second time when she falls pregnant, she'll be a lot more aware and careful and take all these recommendations. But we didn't see that, Alex is doing part of the PhD. See there, no? J? Is Alex here? No. Oh, maybe on Zoom. Oh, okay. Yeah, forgot. That's Zoom cohort. So, what we're seeing is actually even the experience of pregnancy complication didn't really change their kind of preconception behavior.
Yeah,
that's interesting.
I'm hoping to explore some of that through qualitative work, I think.
Why?
To find out why or what could help. I think there's some research at Monash University where they're also focusing on interpregnancy and developing sort of information resources based on what women need. Yeah,
so that's in a really interesting space.
There's a question.
Yeah,
that's right. So there was one talking about a study at the question, but I think it's more to have a look at that. And then there's this question here as well.
Oh yeah, this is from Alex.
Yes, partner and family violence is definitely came up as well in as really important in when we were identifying priority topics to discuss within primary care. So that is not part of the guidelines, but it did come up as part of our discussions with health professionals and and patients as well. So it's included in our kind of 4 priority areas now, not as a single individual one, but under kind of mental health, but really to highlight, I can't remember exactly what my slide said, how we kind of labeled it, but it was about mental health conditions, but also people's experiences with their mental health, and also things like abuse and violence. Definitely comes up a lot in discussions with the community. So hopefully it'll be integrated in the guidelines and mentioned in there.
Thanks, Danielle. That was amazing to hear that presentation. Just wondering about the appetite for preconception health in men, and also, you know, the appetite for data indicators in that population as well.
Yes, I think it's an increasing, like an upcoming area of research where we don't know very much yet, but there's a lot more being done now. Yeah, there's some men interested. They initially like, but once you then talk to them about it, then yes, they are. So my kind of consumer involvement group I'm trying to get more men involved, but at the moment, out of the kind of 20 people, there's 5 men, and they're on board, and they talk to their friends and things like that. So, and I think when we communicate with them, it's not they just don't know what role they have in, you know, in a healthy pregnancy and a healthy child. So they think that they have a role after pregnancy once the child is there, but they do kind of talk about finances and housing, and that's kind of their role in terms of, you know, supporting mum and supporting the family. But we also know that their health is important as well, in the first place, to improve the chance of getting pregnant and then having a healthy pregnancy and outcome as well. So I think we need more research, but also getting the men. We're doing a project at the moment because men are not involved in research, partly because researchers are not trying to involve them, but also when we do try, we don't get as many responses compared with women. So we're currently co-developing recruitment materials to see what language do we use on a poster to actually get, because if the word pregnancy is there, then a man would already realize, no, this is not for me, but it is for you, we want you. So we're kind of, you know, we want them to create the recruitment materials so that we can recruit more of them. So yeah, there's a lot more work being done. Yeah.
Danielle, one question.
Yeah.
Preconception period, how do you define it?
Let's not define it. So in our 2018 Lancet series, there was we couldn't define it either. There were 3 definitions. And I don't know that we still haven't moved on from that. I think I like to think about it it depends on the research question. It depends is the answer, but I like to see it as, you know, what the kind of images I showed, to kind of think about it from a life course perspective. Because even things like, we're writing a paper around paternal preconception health as well, and a lot of the focus there is on mental health as well, and adverse childhood experiences. So men with those experiences and their kind of trajectories in terms of their mental health and how they support their family is like a really big thing as well. So I'd like to kind of, there's multiple definitions. I like the life course version of things, because it's not just about what happens in the week before conception or the 3 months, which from a biological perspective might be most important, but you can't change it in a few months, a lot of things. So yeah, that's my
Okay, so thank you so much.
Thank you. Try and get this sorted.